thank you so much for joining us for another episode of BurnCast. It's like a podcast, but about burns. Last time we did this, we talked about burn therapy for occupational therapy and physical therapy, and I made a joke saying that we weren't talking about our feelings, but today we are. And we have Dr. Carrie Tully, and she is our burn psychologist, and she's going to explain what her role is in the burn team and why feelings and mental health is so important, particularly to burn patients. And of course, we have Liz Weibel and Ann Sorello on as well.
Great. You want me to share a little bit about what I do for the burn team?
Yeah, and like
my background.
Your background, who you are, what you do,
Sure.
Why you care, all the things.
Sure. So thanks for the invitation to come and speak with the group. My name is Carrie Tully, like Cindy mentioned. I'm a clinical psychologist, and I've been working with the burn and trauma team since 2017, actually. So I am an attending here in our psychology division and often have trainees working with me in different roles as well. So what we do with the burn service is we try to be a bit comprehensive with our approach. We focus a lot on the ambulatory care with our outpatients here at Children's, just because there are such high numbers. And we attempt to do psychological screening with each family that comes through the door. So we focus on looking at traumatic stress. We look at child quality of life over a number of different indicators. And we're also looking at some behavioral symptoms for kids as well. And then we do brief interventions with those who need it, referral and treatment for those who need a little bit more extensive treatment. So that's on the ambulatory side. We also do see inpatients as well. So the way that typically works is that the way that it has worked most often and most efficiently is that the NPs for the burn team will email me when there's a kid who might be in-house or might be here for a little bit of time, who needs a little bit of extra support. And then a member of my team will meet with the family at bedside, we'll do an evaluation, and we'll provide intervention. We typically will follow kids for as much as up to like 2 or 3 times a week is probably the highest capacity that we have to see families. But sometimes it really is just like one consultation and some delivery of recommendations, and then that's it too. So there's a lot of kind of variety of what can happen on the inpatient side. On the psychology team, we have a number of outpatients that we see that we refer to ourselves from these inpatients or from clinic. So right now I'm coming to you from our clinic space in Tacoma, which is where our behavioral health center is at Children's National. So it's 6833 4th Street. It's just in like the northeast part of DC. So this is where I see all of the outpatients. So there's a number of patients that I've followed for months or even years, of kids who I originally met while they were inpatient or met them while they were coming through outpatient. And now I provide pretty standard psychotherapy services to them, as well as my trainees. So there's a lot of variety of what we can do. We try to have some interaction with almost every family, but sometimes it really might just be that we have screened them with like a 5-minute questionnaire, and then others we're involved with for years. That was a long answer.
No, there's so many things that I think that you're involved in that if you are an inpatient nurse, you have no idea like the support that the patients are going to get. Sometimes we get so focused on like what's in front of us now that we forget about like the aftermath. So in your background, have you always worked with burn patients?
No. So in some ways, I'm a bit of a trauma person for a longer period of time in my training. So after undergraduate training, I did a research assistant position at a VA in California. And so it was like 2 years of a lot of PTSD research. We talked a lot about diagnostics. We looked at a lot of novel pharmacologies, a lot of novel psychotherapies. So I sat in the room when they were doing a lot of coding of sessions. And so that was kind of like the beginning of some of my interests and how do people overcome really horrific things that they've gone through. I did graduate training and I took more of a health focus through that. So I did a bunch of things with eating disorders. I did a lot of things with kids and families with anxiety disorders was a big focus of mine during grad school. And then I did fellowship and internship, really all just in pediatric health psychology. So kids and families with chronic illness, with injuries, dealing with any kind of thing that interfaced with the health system. And I started working for the first time with burn patients when I started working with you all in 2017. So it's not a population that I've been working in for decades, but I think I brought a lot of my experiences from trauma, from anxiety disorders, even from eating differences in eating behaviors. Like I did my master's thesis in disordered eating, and I still use a lot of those principles about appearance oriented concerns, all those things. That there is a lot of application in different ways.
No, that makes complete sense. It's kind of like your whole like academic career kind of led you to this population.
Right. Yep.
Do you so you don't see every single burn patient?
I don't see every single one.
Okay.
We would like to see most who come through our clinic, like on the ambulatory side. And we try to, but we still aren't there yet just because of a lot of different factors. But I don't see every inpatient either. It really is when I'm consulted. And so that's typically something that's driven, like the NPs are usually involved, I think, in that decision making.
And so say that there is a bedside nurse who is like, wow, I'm really worried about this kid. Should that bedside nurse contact the nurse practitioners, or could they send you an email, or do they talk to like a resident or a fellow, or and then in that, if they ask somebody else to consult you, would it be like, could they reach out to you if they had a question on like how to provide better care for these kids? Or I want to be able to help. Like,
for sure.
I feel like there's so much of like mental health that bedside nursing does, but it also takes a lot of time. And sometimes I feel like we feel inept of like, I don't even know how to help you right now. I just know something's wrong.
Yeah, no, I think those are all great questions. So I mean, I'm always open to being contacted. So you're always welcome to contact me. I think the way that it has worked has been that it's just, I don't actually know all the details of how it's discussed between the bedside nurses and the nurse practitioners, but I think it's also important to know that there are a lot of things that are still within the realms of normal. Like distress is normal. So having a lot of distress isn't always something that triggers a consult, I don't think, because there's a lot of distressing things that happen. And coping, there's no one good way to cope. There's no like one size fits all. There, even in coping research, we don't talk about there being good coping and bad coping. So there can be a lot of things that are happening, and that can still kind of be okay, I guess, is one like big takeaway that I want people to hear. Also, soon in after something really bad has happened, like a trauma, things can be off the wall and really dysregulated and really disruptive. And then that same family can be totally fine 1 week later. That's pretty common. So I would say if a bedside nurse is seeing something that they're concerned about, I think getting some more data on that, like what is it that you're seeing that is so concerning? Is it something that we're worried could be a long-term problem? Is it something that you're seeing that could have like safety level concerns? Is it something that you're seeing that is setting them up for some really bad patterns after they leave the hospital? Like their health behaviors are all out of whack. They're sleeping when they're supposed to be awake, and like vice versa, stuff like that. You're seeing a really bad dynamic between the parent and child, where the parent is, invalidating the child's feelings, or something that you're like, it would be helpful to nip this in the bud because it could grow into a much bigger problem. Those I think are great times to consult. Or if you're having some real concerns about acute stress disorder. So the child is talking, both sides of it, talking a lot about the accident or whatever left them in the hospital, overly perseverating on it with a really, really negative affect about it. Talking about it when it just happened is normal. Sometimes parents can't tolerate that, but that is okay for that child to do. If the child is talking about it and they're crying and they're super upset and they're like stuck on it, well, that's a different thing. Okay. So, or if the child is like never talking about it. So people come in and out of the room. And I think that's really normal for a lot of people to say like, oh, what happened? If the child is like, will not say a word about it, sometimes that's normal, but sometimes that can also be a sign of some avoidance that could get in the way in the future. So I think some signs of acute stress are great reasons to consult, because it is kind of tricky to tease apart, and I don't want to overburden people with trying to figure out what is and what isn't. That's my job, and I'm happy to do it. But also just, I hope you hear my voice say over and over, things can be really crazy I mean, I'm not supposed to use that word, but like, and that can still be really normal. And they won't always stay in that same heightened state over time.
How and I guess I feel like this might be a tricky question, because every kid is different and every experience is different and every injury is different. But do you have like an average of like sometimes like how you said like a lot sometimes it can go away in a week,
Mhm.
but is it would you say like it's congruent with like the bigger the TBSA, like the more time they'll need, the lower the TBSA, like the less?
Well, so the findings from the literature are really mixed on that. So there is some support for the idea that bigger burns, more severe burns have higher levels of like psychosocial dysregulation over time. And I think a lot of us can think about why that would be, but it's not a consistent finding. So
Okay.
families that have like a 2% TBSA, I mean, really small, that heals very quickly, can also similarly vary out of their patterns for a long time. So it's not a one-to-one. I think what does a big TBSA mean? It often means that they're in the hospital for much longer. And so that can be related to poorer outcomes, but it's actually not because of like the burn. It's because now they've been out of school for 6 weeks and now their sleep-wake cycle is completely dysregulated and their parents lost their job because they couldn't go in consistently. And so it's kind of like the ripple effect of what does that mean for the child. So I guess I would say if you are seeing a bigger burn, I probably would want to be consulted. In part, I think that kid is going to be known by our team for longer. It's good to plug me in earlier so I can try to do some preventative work with families rather than come in at the 11th hour and then try to do a lot of cleanup and I'm trying to catch up and like I don't even know what's been going on. But it's not a one-to-one completely, because there are also some families that might come in and only be there for one overnight and it seems like it's a more minor injury, but that family can be pretty upset for a lot longer too. So sorry, that's not a like simple answer.
No, and I as I was asking it, I was like, there's probably not like a easy answer for this. Anne and Liz, um, Carrie mentioned earlier she wasn't quite sure. Like, there's a lot of details that happen to get a kid to get a kid to her. Could one of you give like an example of maybe if a nurse came to you with a problem, or if you saw a problem when you were inpatient? And I'd like an example of both, like an inpatient time where you called Carrie and an outpatient time.
I think I would definitely say that my answer is probably very similar to Carrie's in that we generally think definitely need a consult in big burns, like big, like teens to 20s above percentage, because they're going to be there for a solid number of weeks to months, and going to be with our team for a long time. So I would say that those are the patients that generally we try and get psychology involved earlier. And it's a given, especially patients who have a really large percentage and are in the ICU for a while. I think you can kind of anticipate that as something where Carrie would want to be involved earlier. The ones where it's borderline, I think usually it's something that you pick up on. Maybe it's a small burn and they're only going to be there for a day or two, but the family's really struggling with even looking at it, or the patient doesn't want to see it, or the guilt. There's a lot of parents who have, I think are like, I just turned my back for 1 second. I think those are times where an inpatient who's not like of the obvious category is when I would reach out to Carrie. And I think those are things that sometimes I pick up on and sometimes the bedside picks up on, when nursing sees, oh, the mom's been saying this, or the patient won't do this or that, because I may be in there for the dressing changes, which is an appropriate time to be in distress, right? Like I cause distress. It's just part of my job, right? So that is like a normal time to see some of those behaviors, but it may be the other times during the day that bedside nursing may pick up on that. And then you asked about outpatient. I think one of my biggest things in outpatient is that I know that Carrie tries to see as many patients as she. There's a patient in clinic that is having a hard time returning to normal or their routine, or we're saying time to go back to school, and they're like, oh no, I can't go back to school. or the babies who don't, or the toddlers who don't want to get back in the bathtub, or something like that. I find those are big triggers in the outpatient world, or at least reasons. Or parental guilt, again, can sometimes be something where they're really, kind of perseverating on the injury. I think those are times when I try and reach out.
And do you put in a consult in Cerner, or do you call Carrie first and go like, hey, can we talk about this kiddo? Or do you just like, how does that process work?
I usually email Carrie and say, hey, Carrie, if you have time, here's the reason, here's the patient, here's how long I think they'll be here, here's the reason I'm consulting you. If it works, or when I think they're going to be in clinic, if I'm in clinic and Carrie's there, I just come out and grab her and say, if you have time, can you see them? And if she's not, then I will email her after clinic and say, if you have time to reach out to this family. We also have a handout from Carrie that we provide to patients. So I will give them that and give them the phone number, but I'll also say, like, I'll ask her to reach out to you.
And then, Liz, could you talk a little bit about how, like what burn rounds is and how, like how that works? Because Carrie, you go to burn rounds as well, because I've heard you, like I go as well, and I've heard you give like incredible insight on some kids. But since Liz runs burn rounds, I'd love to hear her kind of explain it, and then maybe you could like add some thoughts to like what burn rounds is, and like when it is, and like what we do there.
Absolutely. So Burn Rounds is a weekly meeting of our entire multidisciplinary team. So this includes our burn attending surgeons, our nurse practitioners, Dr. Tully, our bedside nurses, educators from all of the units. If a child is admitted to the ICU, we'll have ICU critical care physicians at the table. We'll have the patient's bedside nurse at the table. So really, it's a forum to discuss the current state of the child's care. It's a way for the care team to ask any questions about upcoming ORs, or, our case management is there as well. Social work is there. So it's really every single member of the team, PT, OT, rehab, if the patient is slated to go to rehab in the future, it's everyone on a Zoom call, reviewing photos, reviewing individual cases to collaborate the best way to care for the patient and their family. So not only do we review every patient who is presently admitted, but we review patients in clinic that either have surgical needs or psychologic needs that Dr. Tully is following closely. And then we have a big, what we call an inactive population, and that doesn't really summarize it too well, label it too well, but patients that we're following for the long term. So we really try to make it a point for our patients who have more acute needs initially to follow them for the long term, at least for 1 year, and then annually. That's kind of the model that we're trying to use right now. So again, burn rounds is really, it's a face-to-face meeting, well, over Zoom, where the entire team looks at the entire care of that patient, again, from acute burn care to OTPT rehab needs to long-term care, and whether we need to add in some scar management, interventions, et cetera.
Carrie, do you find that like a helpful thing on a weekly basis? Like, are you able to gain like more insight on like what's going on with the kids because of that?
Yeah, it's something I really value. And it's funny, I was just talking to a trainee saying, I would love to be able to bring in some more trainees of my own to see what that's like to work with such a multidisciplinary team, because I really value hearing all different perspectives about the care that the kids are getting. And I don't know if this is the case, but I try to voice anything that I know about the family that might influence differences in those decisions that are being made. Because I do think that that's a place where it's very collaborative. There's often people bringing a lot of different ideas to the table. And if I happen to know something about, like, this mom is so afraid of doing bandage changes, or actually they're moving out of state next month, so like there's sometimes there's just random information that I have. I do my best to speak up on those things. I obviously don't disclose every detail that I have, so I've been asked that question before, like, how do you walk that line? But I do try to feed back also some information about how the kids are doing over the long term, because that is one thing that I really appreciate is I do get consulted when they're in the ICU, but then I often still see these kids, you know, there's some of them that I've seen for years. And so sometimes the medical team isn't always hearing all of those updates. And so I can share like big graduations, or like so-and-so is doing great and has finally gone back to school, or I don't know. I hope that that's helpful, because I'm kind of trying to do that more for the provider side of like, I think you all see so much of that acute side of it. And then if I can also share like over the long term, the family is doing well, I'm hopeful that that's helpful for providers to hear. So, but I
Find
really
it helpful.
Yeah.
Yeah.
Mhm. Yeah.
Like 1,000%. I feel like, especially when you're inpatient,
Yeah.
and you're seeing families a lot of the times, especially in the ICU, and then even on surgical care, you're seeing people like on their worst day. Like we have parents that are freaking out that they weren't paying attention. Another kid has like a disfiguring injury that they
Right.
may have a scar, literally a scar for the rest of their life,
Mhm.
and they are not coping well with it. I mean, but who would cope well with thinking you made a mistake that's going to leave a mark on your child, like a physical one, forever? But knowing that kids get better from this, and that the whole family is healing after that, is it's like a MasterCard commercial. It's priceless.
Right.
I mean, there's a reason why everybody does what they do. So
Right.
no, I appreciate your updates in burn rounds, because I'm like definitely like on the back burner of burn rounds. I'm the picture girl most of the time of just pulling things up, but spending some time in clinic with Liz and seeing kids get better. I remember we had one kid that was graduating and going out of clinic, and it was like such a special moment. Liz, how long was that kiddo there? Like a year and a half or something?
It was a year, maybe a year, yeah, pushing to annual follow-up. And so, we wish we had a bell or something like that.
Yeah.
Because you realize it's such an incredible journey for the child. It's not limited to just a few visits. It's for some of these kids with more severe injuries, this really, does take years to recover from.
Carrie, is there an age limit for like when you get consulted? Like, what's the youngest that you have done like a session with?
There's
like the 1 week old's parents.
Yeah, exactly. I was thinking of like a 2-month-old that I feel like I was referred recently, because so much of my work is parent facing, especially when it's like 3 and under. I really don't think there is an age limit, because sometimes it's even a higher need for those parents of little tiny babies because of the parent guilt piece that Anne like astutely brought up. And sometimes I even just find myself doing kind of almost like a wellness check, almost like they might get in their pediatrician's office, where I still will do some informal postpartum screening depression assessments with families. I'll check to see just about kind of general parenting practices and principles with an eye towards like safety and prevention of future injuries. So there's a lot of things that I'll do if I get a younger child consult, but definitely please send them to me. Plus they're so cute. I love seeing the little babies. So I thought you were going the other way. I was like thinking about the upper end of the scale, and I was just going to say, whatever we see at Children's, I'll see.
Right.
But
yeah, I was just wondering, like, because I'm like, how do you like talk to, how would you even talk to a 3-year-old that wasn't coping well? Like, I totally get the parent part, but I was like, how does that look? Because I'm sure like talking to like a kindergartner would be a lot different than talking to like a 6th grader versus talking to like a young adult. Like,
right.
And
it's all really different. Yeah. Because like the 3-year-old, you might be doing a small amount child facing there, but it's almost, I would say like 80-90% of that intervention is parent facing, and evaluation as well. Like you're just kind of trying to hear from the parent, what's the behavioral disruption and how can we get this kid back to normal? Sometimes I mean, I will interact with kids. Like in every evaluation, I do like a little brief description of the child and things like that. I need to do that for insurance to show that I actually saw them. But part of it is just observational too. And sometimes I try to do some intentional modeling too, where I will specifically bring up like, well, how are you feeling about your burn? Because I think there are a lot of parents who are concerned about asking the question or like saying the scary word in the room. And so sometimes I'll try to destigmatize it and do some modeling with parents. But you're right that the intervention at 3 is really different than 13 or 23.
So
May I ask a question?
Yeah.
oh, please do.
So, can you give us a brief overview? Because I feel like we hear the word or acronym PTSD all the
Yeah.
time, about kind of acute stress, traumatic
Mhm.
stress, PTSD, and how that looks like in our patients, especially in the first few weeks when we're seeing them inpatient or in their like acute period of being
Yeah.
in clinic.
Sure, that's great. So traumatic stress is kind of the descriptor that encompasses both of those things. It's all about how much time has passed since the bad or really scary thing happened. So if the bad or scary thing happened less than a month ago, but you're very, very distressed across a couple different domains, and I'll go into them, then we code it under acute stress disorder. If it's more than 30 days, then it's post-traumatic stress disorder. And it's really the same symptoms. It's just about how long has it been there for. If you're still having it 3 months plus, then you can even have a qualifier of chronic post-traumatic stress disorder. So it's really just about the length of time. Acute stress disorder is not even available as a diagnosis until it's been at least 48 hours. So there's at least some recognition, even in the DSM, of like, things are going to be very, very disrupted right when something bad happens. And the symptoms are things like having intrusive memories of the trauma. And again, that is memories paired with that affective component. It's not just that you're thinking about it. What I often say to my kids is, it's like a bad movie is playing in your head all the time and you can't find the remote to turn it off. So it's the memory, but it's also making you feel really sad or really down or really dysregulated or really upset, really mad, something like that. It's also can be avoidance. So avoidance of reminders. That can be internal triggers or external triggers. So for a kid with like a burn injury, it might mean this kid is never going in the kitchen. And like the kitchen is central in the house. And so this kid is taking all these weird routes all around the house to avoid going in the kitchen.
Do kids do that?
Yeah.
Wow.
Yeah.
Yeah.
Sometimes.
I never thought of like that
And-
being a thing.
But I will say, if someone tells you he never goes in the kitchen, the next question should be why? Because I find even more common that parents aren't letting their kids in the kitchen anymore. So it's actually parental avoidance.
Huh.
It's like not actually the kid. The kid is
In-
like happy to be in there and the parent is just terrified.
They're like, I'm never going to eat soup again. I'm like,
Exactly.
"Oh, I think maybe in
Yeah.
your life you should try some.
Right.
Like, yeah.
Right. And again, some of that like over the top hyperbolic, especially like I'm a teenager,
Right. Yeah.
it's like totally normal. You kind of want to check in on that belief over time. If that's what they're saying at day 3, fine, let them have it. But if we're still saying that at like day 60, well, now we need some intervention around that, right? So like it kind of is dependent on time. So we have intrusions, we have avoidance. There's also hypervigilance, which is really kind of that like somatic component where the body has been flooded with hormones. You're still feeling really keyed up. You might not be able to sleep very easily. You can't concentrate. So it's all of those kind of pieces. And then there's a mood component as well. So for kids, that can be an irritable mood, that can be a depressed mood. So it can present in kind of different ways. But whether we're talking about parent or child, it's the same 4 core symptoms: intrusions and avoidance, mood, and hypervigilance. And then the distinction is the length of time out since injury.
That was Anne, thank you so much for asking that question, because I had written down on my notepad, ask about acute stress.
Sorry,
And
I hope
what's
I
the
didn't
difference?
steal your question.
No, I was like, but I feel like you asked it a lot better than I could have, because I was like, what's the difference between acute and post?
Oh, can I say one more thing about that actually?
Please do.
Intrusions can also be nightmares. And I feel like people know that, but just so that I say it intentionally, it doesn't always have to be just like daytime memories. It can be nightmares. And for kids, the nightmare does not have to be about what the bad thing happened. Like you don't have to hear from a kid, oh, I had a nightmare about getting burned, for me to code that as like related to PTSD. It's just, they didn't have these significant nightmares before. Now they're having them all the time. That's like a traumatic stress symptom.
Do parents ever think that if you talk to them about that in particular, and will they be concerned that if a kid had a nightmare, like if their other kids are having nightmares, even before that, they're having like some response, or like I don't know if I'm explaining that right. I feel like parents would probably be like, oh God, like did something else happen to like my other child or
I could see parents wondering about that. I would
Yeah.
also just say like nightmares also are just really normative. Kids
Yeah.
have nightmares, right? Like all kids do, and they
Right.
can be really episodic. So I focus a lot of my evaluation on like what was there before and what is
Right.
new, because
Okay.
I do meet a lot of kids that have a lot of pretty dysregulated behaviors or like pretty strange sleep habits. And I think we can get excited about that. But then when I'm like, oh, but he was also doing all of this before, I'm still happy to provide some intervention around it, but it's no longer like a traumatic stress intervention. It's just kind of more general behavioral parent training pieces, if that makes sense.
Well, yeah, because it's not just like perfectly healthy, never had a problem kids that get burned. We have kids that have normal problems. We have kids that have more than normal problems.
And we have a higher incidence than normal of ADHD symptoms, which is where some of my research has focused over the last couple of years. So we have 4 times as many kids with ADHD symptoms in our burn clinic than you would expect to see just like walking around on the street. And it makes perfect sense.
Wow.
It's that impulsivity, right? I can't accurately judge danger. I also don't have that like stutter step in my executive functioning to think like, oh, if I do this, it's going to really hurt me. So you're right that kids of all walks of life get injured, but some kids get injured at higher rates too.
Can you and Anne and Liz, you might be the ones to explain this, but can you explain why it is that every toddler has a cold before they get burned? Like, what's that about?
So I have a theory. That when little ones don't feel well, they're a little more clingy. You don't really want to put your little one down. So maybe you're exhausted. You try to, grab that cup of coffee, little one grabs your arm. So so usually, or, if there could be more hot substances around again. You're warming up some tea for a school age kid, or you're steaming. So yeah, running a warm bath to kind of get that steam in there too, or a shower. So
also we know from injury prevention literature that it's when everything is not going according to the family's normal plan that the child is at a higher risk for injuries. So if the kid is normally in daycare, but mom had to call out to keep the kid home because the kid has a cold, that also sets the stage for like, now nothing is running the way that it's supposed to.
Oh.
And that's when more systems can fail and lead to more injuries.
That makes sense, especially like around the holidays when you have
yeah.
more people in your house, you're cooking different foods, you're using different, I feel like all of us have done some type of cooking around the holidays where you get that dish out that you never use except for like once a year or, that makes sense.
We recently talked about a patient who, in the setting of many patients, about something as providers that we could do to kind of support them. And one of the things that we've spoken of is not saying, oh, you look so good, especially or this looks good, because I will open up a bandage that the family may not, or the patient may not have seen in 5 to 7 days. And I'm like, oh, this looks good, it's healed. And they're like, well, that's not healed, right? Like that's not what it looks like.
The color isn't back, nothing looks normal.
Yeah. And I know that patients with scars are like, this doesn't look good to me, but everybody says it's good. It's like we've tried to focus on, and I've tried to focus on in my practice, although it's really hard to say like, this is what I would expect at this time. And this is like a great healing trajectory or something along those lines. Carrie, can you I know you've gotten that feedback from patients without divulging too much information from a patient specifically, but do you have anything else like that we can improve as providers when we're approaching patients like this? Or maybe that's just the real big one that we all
I think that is a good one for this population, especially thinking about labeling it like that looks like it's healing well or something like that, just being a little bit more descriptive. And I think it comes from a really good place as providers, because you want to provide reassurance. You're also excited. You're probably happy with your findings. So I think it's coming from a good place. And I think in the times when I've talked with patients about it, they recognize that side of it too, that it's not being said with maliciousness, but it just triggers for them some like negative feelings and thoughts about how they think it looks and those types of things. Another thing that comes to mind that's a little bit, this is kind of related, it's not exactly related, is I recall a family I worked with, it's been a couple of years, but I remember that there was something happening on the inpatient unit, and for whatever reasons, like some stickers had been placed on some of the doors. And I think it was like a completely innocuous thing. Like perhaps it even meant something to keeping, like make sure you're cleaning this room. And this parent was pretty distressed about her child's burn. And she thought that the sticker meant this is a problem mom. And
Wow.
so I think the takeaway that I would like this team to hear from that is if there are changes in the environment, even if they're fairly small, it might be helpful to connect with parents and just tell them like, oh, this sticker actually means that your floor needs to be vacuumed or something like that, because they ascribe meaning to everything and every interaction that they're having with you. And especially anxious parents or parents who are feeling really guilty. Sometimes they're also kind of the parents that are harder for the team to communicate with, to be honest with you. They're looking for anything. And so I thought that might just be a helpful example that I had heard about once, that I was like, oh, I wish I could go back in time and just have given that feedback in the moment, because I'm pretty sure that like we don't have that sticker.
We do not. We do not have that sticker.
But
We have
like,
a lot of decorations and stickers and various things
Right.
and labels, but we don't
have the like problem parent sticker.
Yeah. No, we don't.
Yeah, we used to have the communication needs chiclet, but that was if we had like a deaf family or
Language interpreter.
yeah, it was
like
all
interpreters.
right. It wasn't anything like I used to make a joke and put it on there on my tag that said like I have communication needs because I'm special, but even that I think we have to be like really mindful like how the chiclets are used.
Right.
Yeah.
So in wrapping up, first, I just want to say, Carrie, thank you so much. I feel like
Yeah.
this is really enlightening for even for us that know you and know what you do and like know how like we're just so glad that you're a part of this team.
Yeah.
And like you're the first person that we call when we are sensing feelings. But Liz, I'd love to hear like what your major take home for today is, and then we'll end with Carrie and just like whatever you feel is like the drive home notes for our bedside nursing staff.
Okay.
And Liz, we'll start with you.
Yeah, I think I had never thought about those first couple of days post-injury, that disorganization, that's normal, that the chaos is normal. So I think just, validating that for child, for parent, for everyone, and for the staff is really important. And I think that would be a great message to get to our nurses, who are there with the family for 12 hours at a time, that this is going to be okay. I know it's hard to believe right now, but we will get through this. This is normal. And we're here for you as a team. So I thought that was definitely some incredible food for thought.
Anne?
I like the piece of information that speaks to the amount of distress is not correlate with the size of the burn necessarily, to really keep in mind that while certainly a lot of our big burns have trouble, the ones that are between, I guess, like 2 and 10, 12% are like, even some of those like less than 5, less than 10, they can have just as much trouble. Because it's not necessarily based on the size of the burn.
And then Carrie.
Yeah, I guess I just appreciate the opportunity to chat about some of these things. And I'm glad that one of the takeaways was about normalization, because the thing that keeps me doing the job is getting to walk side by side with someone through their resilience and helping them identify what it is for them, because it's not one size fits all that's going to carry them through. And not every kid needs therapy after a burn. And you would think that a psychologist would say that they did, because that's good job security for me, but it's actually not true.
Mm-hmm.
So most of them actually bounce back really well. And so we're really focused on figuring out what is the formula for this kid, for this child, for this family that's going to help them get there. And then I'm here as a safety net for those who might need a little bit more support.
That is, that's just, it's amazing. And And just like a plug for Burn Rounds. And we do this, Burn Rounds is every Thursday on Zoom at noon. And for anybody watching, if you are interested in joining, just email myself or Liz or Ann and say you want to be on that list. And you can join us if you want to learn more about burn patients and really see the multidisciplinary team in action. I think you would be surprised at like how detailed it gets with every single one of our patients. So thank you guys so much for watching, and we'll see you next time.